one gentleman. And I'm sure some gentlemen will be online. Yes. So this afternoon, we are going to have a presentation on premise and newborns, innovative tools and care strategies for improving the outcome of babies born out of hypertensive disorders of pregnancy. And it will be taken by my teacher and my senior colleague, Dr. Emmanuel Pabi. Please, let's clap and welcome him. So the whole session will be 1 hour, 30 minutes. Dr. Pabi has 1 hour to make his presentation. If he can do it in less, that's fine, but he has 1 hour. And then we take the rest of the time to discuss, ask questions, and then conclude. Okay, thank you very much.
Thank you, Hectoria. All right, so you are all welcome to this section. And since we are very few, I hope that it will be very interactive. Okay, so I'm to talk to you about it. For improving the outcome of babies born out of hypertensive disorders of pregnancy. All right, so next slide, yeah. So basically, most of the babies that are born out of hypertensive disorders of pregnancy, majority of them will end up in the NICU environment. And I'm sure maybe some of you have experience with the NICU environment. Next, yeah. So my objective this afternoon is to discuss the factors that influence the outcome of newborns or preterms. And then also to give an overview of some of the outcomes of the newborns and preterms that we have in our various facilities that come out of hypertensive disorders in pregnancy.
Well, we can apply to bottles, but then it means you have to change the prescription for us. So you would have to change it to syrup. That's why they send a picture for me. Let whoever is there.
Yes, ma'am.
So, Mr. Gama.
Maybe those online, if you can mute your mics, we'll be very grateful. Those online, if you can mute your mic, we'll be very grateful to minimize the interruption. So in my attempt to give you the overview of the factors that affect the outcome of preterms, and then also tell you about some of the outcome of preterms and newborns in our environment, this will be my outline, talking about the factors that influence newborns' outcome, some innovative tools that can be used, and then what newborns need, the preterms, what do they really need from us, and then some of the care services that are available in our environment, and then the outcome of the preterms in our environment. So by way of introduction, the survival of newborns or preterms are influenced by several factors. And these factors are very complex. It's not just simple. It's not like you know that factor A influences the outcome of newborns, and so once you take out factor A, then you are done. It is not like that. Maternal health status and the support that you get, like you say, it takes a whole community, isn't it, to get the right outcome when it comes to pregnancy. Like they said, if a Muslim lady delivers, the whole family comes to what? To support her, to take care of the baby, and because of that, you don't tend to get some of the challenges that other people tend to get. The same way, for the newborn to survive, it takes the whole community to come together to support the mother so that the baby will come out well. The interplay of these factors is very complex, and that is something that we need to know. Knowledge of these factors will empower us, the healthcare workers or the care providers, will empower the healthcare providers in order to improve the outcome and then the care that we give to these babies. If you know factor A, B, C is likely to affect the outcome of this newborn, then you put in some measures to mitigate its effect. So it is very important that we know what our babies are at risk of, what will affect their outcome, so that we will put in measures to help with the outcome. Next. So what are some of the factors that influence the outcome of newborns? One of the key factors that affect newborns in our environment, especially newborns from hypertensive disorders in pregnancy, is gestational age. And I hope you understand gestational age, how old the pregnancy is in terms of the weeks. So the lower the gestational age, the worse the outcome. The more likely that the baby is going to die. The higher the gestational age, the more likely that this baby is going to survive. And we've learned that most of the preeclampsias or hypertensive disorders in pregnancy tends to occur when the pregnancy is still very young. It's still in the 20s and the 30s. And at that time, if the baby is forced out, it becomes very difficult for the baby to survive. Then the birth weight. The birth weight is also key. The higher the weight, the more likely the baby is able to survive. So you take two babies who are all born at the same weeks, like 30 weeks. If one weighs 1.2 and one weighs 1.4 kg, the one who weighs 1.4 is more likely to survive compared to the one who weighs 1.2. So the higher the birth weight, the better for the baby as well. Then APGAR scores. If the baby is born and the APGAR score is 9/10 or 10/10, the outcome is very good. If the APGAR score is 3, 2, 1, which sometimes happens, that also affects the outcome of the baby. So the higher the APGAR score, the better the outcome. And the lower the APGAR score, the worse the outcome for the baby also. Mode of delivery. I think for the last presentation, she mentioned that the factors that affect the outcome of the mothers, and she mentioned cesarean section as being one of them. So the mode of delivery also affects the chance of survival of the newborns. Once a mother goes through cesarean section, most of the time, we know that the mothers who have hypertensive disorders in pregnancy are likely to have emergency cesarean section, isn't it? And so it also tends to affect the outcome of this, because the babies are not prepared. They are just lying there, sleeping comfortably. Then, because of hypertension, they say, hey, come out, whether you are ready or not. They just push you out of your environment like that. I don't think you'll be happy if any of us is treated that way, isn't it? Yeah, so it definitely also affects how they also respond to us when they come out and their survivability also. The place of delivery is also very important. We've heard this story so well. Our main executive director, she said when she delivered outside, because of the equipment, the support, everything that she had, so the baby survived. And we know that babies that are born too early or from hypertensive disorders tend to do better in developed environments or in developed countries than in lower income countries or than in the developing countries, just because they have access to everything. The same way, even in Ghana, if a preterm baby is delivered in Korle Bu, the chance of that baby surviving is likely to be higher than if the baby is delivered in Fanchebra or Fanchenoko or something. I hope you get it. So even in Accra, depending on the facility that you are born in, you are more likely to survive than if you are born in another facility. So the place of birth is also very, very important. If a baby is born maybe in one of the polyclinics and what have you, that baby is likely to be transported to even Korle Bu or 37 or Ridge for care. And even the transportation and everything will affect the outcome. If that baby is delivered right there in maybe Ridge or 37 or Korle Bu, that baby has a higher chance of surviving, even though they were all delivered in Accra. But the facility in which you are delivered may also influence your outcome. Antenatal corticosteroids. Once you want to deliver a pregnant mother prematurely, normally you want to mature the lungs, so they give antenatal corticosteroids. Evidence has proven and shown that if you are able to give the antenatal corticosteroid to the mother, the babies do better than if you don't give it. And so it is also very, very key. But sadly, sometimes when we are doing the audits, you realize that either it was omitted or it was forgotten or because of the emergency situation. Because if you come in and you are fitting, we can't now give you the steroid. We are not thinking about giving you steroid and all that. We are thinking about saving your life. So quickly we will whisk you to the theater and deliver you of your baby, isn't it? And so sometimes that is also not given. So babies that come out of pre-eclampsia and eclampsia, sometimes they don't get, even if they will get, it will be maybe 1 dose. And we know that minimum you need at least 2 doses, isn't it, in order to improve the outcome. So hardly would they get all the 2 doses before they come out. Most of the time, just 1 dose, or sometimes they don't even get. So that also tends to affect their outcome. And then respiratory support. If you are preterm, you come in, you have difficulty in breathing, you need oxygen, you need equipment, you need everything that you can. Because you are not prepared and you have just been brought out. You have to survive by yourself all of a sudden. So it takes a great toll on their respiratory system, and they need respiratory support. How many of our facilities have CPAPs? Even oxygen. How many of our facilities have continuous oxygen? Sometimes it's just cylinders. You put these babies on cylinders. By the time you close your eyes and open, the oxygen is finished. And you now have to go and look for a different cylinder to come and give this baby. So that also affects. And the length of stay. The longer they stay in the hospital, the higher their chances of what? Of dying or of not surviving, sadly. This is so because the hospital environment is not a friendly environment, is it? The longer you stay in the hospital environment, you'll be receiving injections, they are withdrawing your blood, they are poking you, they are checking your temperature, they are so many things are done to you, and it stresses you. It stresses this newborn. So the longer they stay in the hospital, the less their chances of also surviving. Then availability of surfactant. We know their lungs are not mature, so they need surfactant. Most of our mothers will not be able to afford surfactant. Very few people are able to afford the surfactant. And even getting it in our environment is very difficult. If maybe because of 1 or 2 things, we know that we are going to deliver you premature, maybe in the next 48 hours or so, then some arrangement can be made so that we can look for it. Most pharmacies don't stock it because it's expensive, and because we don't use it often, most people are not able to afford it. So they don't, because if they stock it, it will expire on them, and then they will be at a loss. So most people don't stock it. So anytime you need it, you have to struggle before you get it. And then I've mentioned the CPAP, the clinical state of the newborn baby. Evidence has shown that if a baby comes in and he's having difficulty in breathing, struggling to breathe, chest indrawing, lower chest indrawing, flaring of the alar nascent, the baby is sinused and all that, that baby is not likely to make it. Compared to a baby who is lying down comfortably, breathing normally, very pink, and everything is fine. So the state in which the baby comes also will also affect the outcome. The duration after birth before presentation to the NICU is also key. Like I mentioned, if you are delivered in a polyclinic or a health center or whatever, you have to be transported to the tertiary facility. The time it will take for you to get there and all that also affects the outcome. So babies that are born in facilities that have NICU tend to do better or tend to survive better than babies that are born from lower facilities before they are transferred to NICU. So most of the time, obstetricians, if they don't have access to NICU facility in their hospital, they will want to transport the baby, whilst the baby is in the mother's womb, to a facility where they, as soon as they deliver, they can have access to the NICU in order to increase the chances of survival of the baby. So it is very key. If you know that you are going to deliver a premature baby, and this baby, you don't have NICU facility after delivering, the baby will have to travel and go to another place. It is better to transport the baby in the mother's womb if situation will allow you, rather than delivering the baby before later making an attempt of sending the baby away, because it affects its outcome. The quality of antenatal care. A lot has been said already about antenatal care and its influence. And when we say quality, we mean quality. For instance, the case, the audit that was done, the mother, even though she came late, that is one, she came late, some vitals were taken, duly recorded, but no action was taken. So she came for antenatal care, but did she receive quality care? I doubt. She didn't. So it's not just coming for antenatal. Oh, how many times are you supposed to come? At least 4 times or 8 times. So I've come 8 times, 10 times, 12 times. No, that is not it. What service was provided? What was the impact of the antenatal care on the pregnancy and the pregnancy outcome? Compliance to ANC medications. I am sure some of us, we know, we are very stubborn academic children, isn't it? And stubborn academic mothers. Sometimes when we are giving the medications, we don't take them. Today we take, tomorrow we forget. Like some friends that I have, you give them medication, they won't take unless they are dying before they will take it. So it is very important that we stress on the need for them to comply on their medication. We learned that calcium helps prevent preeclampsia, isn't it? Either way. They say when they give the mother, they say the tablet is what? Too big, so they won't swallow. Meanwhile, if you look at the tablet and their fufu, the morsel of fufu that they swallow, the fufu and the banku is bigger than but they will not. So we need to stress on this. It is very, very, very important. Because if they are on their medication, you give them antihypertensive medications, something that they don't take. And that will cause the blood pressure to go up, leading to problems. So we need to stress on the need for compliance on their medication. The physical state of the mother. Of course, if the mother is healthy, then you expect better outcome. If the mother is malnourished or no accommodating that, definitely the baby will be at risk. So we need to emphasize the need of the mothers to also take care of themselves to make sure that they are physically strong. If they are working too much, they need to take some time, rest. That is why about 6 weeks to your time of delivery, it is expected that you start your leave. But modern day women, what do? We will wait till we go in labor whilst we are at work. Is that not what we do? Because we want to maximize the post-natal period leave. But there's a reason why the advice is take 6 weeks leave before you deliver and then after that. So we need to look at that also. And then the psychological state of the mother. If you don't have enough support and all that, your breast milk may not even flow. You will not get breast milk. That will help the baby to also survive. So we need to also ensure that they have the support that they need. Some husbands are never present. Isn't it? They are there, but they are not there. You see mothers or women always coming to antenatal, and the husband will not follow them even once, which is not good. I don't know, maybe because I'm a doctor, but I've followed my wife for every antenatal visit. I will go because I want to know what is happening. Maybe because I take care of babies also, so I want to be sure what is happening. I want to know. Most fathers don't do that. So you see the mothers struggling, and you know how your walking change. I always be laughing at some of my friends. You see somebody just struggling, I mean, it is not fair. So we need to support them, these mothers, so that psychologically they know that, yes, in case of emergency, I have somebody who is right there with me to support me. The financial status of the family, that is also key. Finance also impacts on the outcome of the baby. This mother didn't have money, so she didn't even go for antenatal, isn't it? If she had enough money and all that, she would have started antenatal early, buy her medications, everything on time. And maybe the outcome would have been different. We will not be discussing some of these things. If you say you should go and buy surfactant, which is costing 2,000 Ghana cedis, 3,000 Ghana cedis, and you don't have, we will not. So even if it is available, you can't afford. And it will not be given to the baby just because the baby needs it. Who is supposed to pay for it? So money is key. Maybe baby is sick, baby needs antibiotics. You don't have money to buy. Who should buy it for you? So having money is very, very key. Finance is also one of the things that affect the outcome of babies. So what are some of the strategies or tools that we can use to improve outcome? I've summarized this into these 4 key points. And 1, care of the adolescent girls. And I'm happy I saw very wonderful adolescent girls in our environment. Right? In our environment. And these adolescent girls are being empowered. Okay? They are being empowered by way of what? Knowledge. So that when they grow up and certain things are happening, they will be able to make certain decisions. We need to empower the girl child to be able to do certain things. Empowerment of women. I think this is a point that I don't need to emphasize here or overemphasize here. Most of us here are women. I sometimes describe myself as a woman because I work in an environment where most of them are women. I'm just waiting for my skirt. Then I'll change my name. So we need to empower women to be able to make certain decisions. It is very sad when a mother will deliver, they will bring the baby and the mother to the environment, to the clinic. And then when you want to do something, you say, oh, I'm waiting for the father. Oh, I'm waiting for the father to make certain decisions. Oh, I'm waiting for the father. Oh, I'm waiting for the father. When I hear some of those things, I become sad that you have carried pregnancy for 9 months with all its challenges and problems. And for some people, when they are pregnant from day 1, they will vomit until they deliver. You have hypertension, you are swallowing medicine, Your appetite has changed all of a sudden. Food that you didn't used to like, that is what you want to. Soil that you were stepping on, now that's what you want to pick from the floor and eat. You've gone through all these challenges and you have delivered, or something is supposed to be done for you. And then you say, I am waiting for Kojo Mensa or somebody else. We need to empower the women to be able to be bold to make certain decisions for themselves. Because those things causes delay and sometimes also affect the outcome of the babies. Then antenatal care attendance. I have mentioned it already. We need to ensure that our pregnant women are attending antenatal and they are getting quality service. Not just attending, but getting quality service by way of making sure that the red flags, we pick them up, we manage them appropriately, we involve them in the management and ensure a better outcome. Then effective health system. Our health system is, we know, sometimes people say that we don't have a system. But I'm always quick to tell them that we have a system, but it is as what we have is also a system. But it is not the proper health system that we talk about. Where if you come and you need something, it will be given to you. I was at my NICU yesterday. A father came, was complaining. My baby was delivered in some polyclinic. I've already spent 4,000 there already. The baby has been referred to you since I came the first day. Medication that was written for the baby alone was 500 Ghana. Now I am dry. In fact, he took his wallet when we were doing some receipt. And I saw that it was just 1 Ghana cedi too. And I said, hey, I am Pao. And we were all laughing. And I was telling him that, look, I'm a doctor here. I know what you are going through. Ideally, this will not be happening to you. Ideally, once the baby comes, we provide all the care that the baby needs. When we finish and we discharge your baby, we give you a bill, isn't it? And then you pay. But would that happen in our environment? Can a system survive if you decide to do that? So, because we don't do the proper thing, by making sure we provide the care, the system is able to provide the care that everybody needs. And then after that, you can then demand your money. I think that is the ideal thing. But unfortunately, who is supposed to pay? Like I said, am I supposed to use my money to buy the medicine for the person? And then what happens? And in fact, once you buy for them, they will tell you they don't have. And what will you do? Even those who have, once the care has been provided, they will not even have. So our health system is also challenged. What are the things that our babies need to be able to survive when they are born? Especially those born from hypertensive disorders in pregnancy. They need warmth because they are usually very small or very premature. So we have the incubators, isn't it? How available are these incubators in our various facilities where we deliver the babies? They are hardly available. Just this mid-morning, whatever, I was having a discussion with some of my doctors from 37, and they were complaining that, oh, our incubators are not enough and all that. And since I'm a pediatrician, I'm a doctor there, and what am I doing about it? I just looked at them now and laughed. I laughed. Why so? Why so? Because the average incubator is costing about 200,000 Ghana cedis. 200 for just one incubator. A good incubator, quality one that will last. How many of our hospitals will be able to afford 2 or 3? The medical director or medical soup will not see why just one small equipment I should spend 200,000. You put the baby in, you need to charge this baby, isn't it? Or charge the mother to be able to recoup the money to maintain it and even buy another one. How much are you going to charge? Will they even pay? Will health insurance reimburse you and all that? So those are the challenges. So our babies need warmth. And apart from the incubators, Radiant Warmers are also there to provide some warmth. I know in some of our districts, and previously we were using onion bulbs, isn't it? We put hot water in gloves and put them by the side, or water bottles and put them by the side of the babies to keep them warm. And by the time you realize they've gotten burns and all that. I have said it before. So those are some of the challenges that we have. But they need warmth and they need to be kept warm. One of the key reasons why babies that are born outside hospitals that have facilities to take care of them die or they don't do better is hypothermia, low body temperature. Because when they are transporting them, they don't keep them warm. So by the time they come to the facility, they're already hypothermic, their temperature is low. And that is known to affect the outcome of babies. So warmth is very key. We have to make sure they are always what? warm. They are well covered. Early respiratory support by way of giving them oxygen, by way of putting them on CPAP. When they come and you have CPAP and you put them on early, they do better. If you wait till later, till they start struggling to breathe, before you put them on the respiratory support, they don't do better. Because by that time, they are already tired, they are on their way out. And you are now trying to rescue them. But when they come, when they are not in distress, and you start the respiratory support early, it helps them to survive. So early intervention with respiratory support is also very key. Nutrition, breast milk, I cannot overemphasize this, is key. As I said earlier on, if the mother is not well enough, psychologically not okay, breast milk production will be affected. These babies are usually not able to even suck to stimulate the breast to produce more milk also. So it takes days before these mothers are able to produce milk. These mothers may be also in pain. They've had cesarean section, and so they are in pain. They can't do anything. So they don't get adequate breast milk on time to help them to survive. So giving breast milk is also very key. And normally we will start, even if it is just a drop, 1 ml, we start with what we call tray feeding, just putting it in your mouth or through an NG tube in order to prepare the system. You know, colostrum is very healthy, contains antibodies and a lot of things that protect the baby. So it is very important that we don't deprive them of breast milk also. Then stimulation and tactile stimulation. I always say that life, the body is there, but there is spirit in the body, isn't it? And I always say that when you talk to your baby hears. I tell the parent, talk to your baby hears. Once the baby is in your womb, you are always talking. They hear your voice and all that. So once you talk or you say something, they know this is a familiar voice. So when they come, I tell them, talk to your baby. So I tell them, touch him, hold their hand, say something positive. Tell him, my friend, I'm waiting for you. Hurry up and let's go home and go and enjoy life or something. I believe those things. If mothers that are involved in the care of their babies, the babies do better. So we should not unusually push them aside. We should not unusually push them aside. That, hey, don't touch your baby, don't do this. No, let them wash their hands very well. Allow them to touch their baby, to hold their baby. That alone also encourages, it makes them feel good, makes them feel better, and then they're able to also help you to care for the babies. Then medications, surfactants and antibiotics, I've mentioned it. They are likely to, because their immunity is low, they are likely to have one infection or the other, and so we have to give them antibiotics. Because they are not breathing well, we have to give them surfactant, caffeine. They need that as well to survive. Then, after a radiant warmers already, after incubators, CPAP machine ventilators, breastfeeding, very good. And then also minimal touch. You don't need to touch them very often. They have a term, the nurse have a term, they say like all-inclusive care or whatever. When you go to the baby, you check the vitals, you give medications, you look at the diaper. If the diaper is soiled, you change it and everything. So you just don't go, AC Mansa, go and check the temperature. It comes, you go and check the respiratory rate. Then you come, go and change the diaper. So you have 3-4 different people providing care for the baby at the same time. One person goes in, does everything, and then comes out. And allow the baby to rest. Because if not, almost every hour, you are touching the baby. Because baby will remove the oxygen, then somebody will have to go and fix it. Baby will be lying on their hand, and so somebody will go in. So we need to minimize the number of times we touch these babies as much as possible. Then medications, I've talked about it. KMC, kangaroo mother care, is one of the key ways of keeping the babies warm. Like I said, they need warmth. And in an environment where we don't have incubators, the mother's bosom is the next best place that these babies can survive. And in places where kangaroo mother care have been implemented, the outcome of these premature babies have been very, very significant. It has been very, very good. So we need to learn how to do the kangaroo mother care. We say kangaroo mother care, but the fathers can also do it. So whilst the mother is in pain, has cesarean section and is lying on the ward, when the father comes, let the father remove his shirt and singlet, put the baby in the father's chest, wrap the baby nicely. And the fathers that do it, they love it. Because sometimes they don't think that they can also be of help to these little ones. Sometimes they're even scared to even touch them. But when you encourage them and empower them and they offer such services to their babies, they are happy and they are always more willing to help. So let's encourage the fathers. If the fathers are not there, aunties, grandmothers, everybody, anybody can do kangaroo mother. And then phototherapy, they tend to also become jaundice quite often. And so we provide phototherapy services. Counseling of the parent is very, very key. Very, very, very key. A lot of studies that has been done in our environment and elsewhere have shown that the mothers whose babies are at NICU or are born premature, they go through a lot of psychological stress. They don't tell you, but they are going through a lot. Some of them have never delivered before. They've seen babies and they see people deliver and they see bouncy babies, isn't it? Then me, I'm going to deliver and I've come out to their baby that looks so small. They are even afraid to touch these babies. They wonder, what did I do? How come I have given birth to such a baby? So they will be thinking, they will be wondering, so many things will be going to their mind. Is my baby going to survive? Is my baby going to survive? And they come and this baby is lying in an incubator or lying on a cot with some things on the chest, maybe monitors everywhere, oxygen in the nose, and they say, don't feed your baby, don't do this, don't touch your baby. Why can't I touch my baby? So you can imagine what they go through. And then we are shouting at them. Hey, mommy, I didn't know. Hey, they are, in fact, they are. So please, let's do well to. And then post-discharge counseling. When they are going home, we need to advise them, look out for the danger signs and bring the babies back when there's a problem. So this is our NICU environment. This baby lying down nicely. I always say, once the baby is in the NICU, the baby is not well. The baby is sick. So even though this baby looks quite okay, he's not well. The only time the baby will be well is when we say, Mame Joba, Fanuko Fie. Then that baby is well. Next. You can move on. Okay, so this is a baby having a phototherapy, the radiant warmer. Next. Okay, so what are some of the outcome of care? Our understanding and knowledge on the current mortality rates is key to help us improve the outcome. Clinicians are usually faced with critical decision making. Where do I have to deliver this baby at 30 weeks? And when I deliver the baby, where is the baby going to be? Or I should transport this baby in the womb and send the baby somewhere else. Then the knowledge of is also very key in helping towards counsel these families. If you know that the babies that are delivered at 30 weeks always survive, you know what to do. If you know that they usually don't survive, you would also know what to tell the parent. That yes, we will do our best for the baby, but the chances are what? Are slim, isn't it? So how you counsel them, your knowledge will help you. The prevalence of preterm delivery is on the increase globally. In Kolebu, in 2003, the rate was about 9.3%. By 2019, it has doubled to 18.9. My mate, Agbenu Eta, also from Cape Coast Central Regional Teaching Hospital, also did a study from 2010 to 2019. Next, the rate of premature delivery had also what? Even tripled, isn't it? From 2.7 to what? 9. So the rate of preterm delivery in our environment, globally it is on the high. Even in our environment, it's also on the increase. Next. Survival of this preterm, I've mentioned, is highest when with a higher gestational age and birth weight. However, the survival differs from country to country. And like I said, in the developed countries, up to about 89% of preterm babies survive. Compared to lower income countries, only 30 to 50% of the babies tend to survive. From Cape Coast, over the 10-year period, they had overall survival rate of 67.4%, which is quite good, isn't it? Compared to between 30 to 50%. If you are doing 67%, that is very good. But it ranged from 91.6 for babies that are born at 34 weeks to as low as what? 28% for babies that are less than 28 weeks. So the lower the gestational age, the lower your chance of survival. Next. So the survival of preterm babies at the Cape Coast Teaching Hospital, that is over the 10-year period, has basically hovered around the same, between 60-70%. Next. What are some of the reasons why they give for the better chances of survival compared to other lower income countries? Because they say they have what, trained and skilled obstetricians and gynecologists at Cape Coast Teaching Hospital, isn't it? They have trained pediatricians and nurses. They use what, the antenatal corticosteroid that I mentioned, and even magnesium sulfate in the management of the mothers who have hypertensive disorders. Pediatricians attend high-risk deliveries. If the baby is at risk of being delivered early or a problem, they call the pediatricians to come in and stand by. So that as soon as the baby is delivered, they intervene. They provide warmth. They have incubators. They use KMC also. They breastfeed. They help the mothers to what? To breastfeed their babies. And then they prevent and also treat infections. And they have CPAPs also that they use. And so they think that because of these reasons, that is why their babies are what? Surviving. And of course, if the babies get all this support, they are likely to what? To survive. Next. Now, they found out that babies that are born from outside their facility, that were brought to their NICU, had the 3 times chances of what? Of dying. As I mentioned earlier on. So if you are born outside the teaching hospitals or outside the facility that have the NICU, your chances of dying is higher. The question is why? Is it a type of delivery, transportation, or because of the delay before you are sent to the NICU? There are so many reasons why the babies don't make it. From 37, the year 2022, we had 557 admissions to our NICU. Preterms made up 32.8%. Our overall survival rate was 70.1%. That is comparable to the 68% from the Cape Coast Teaching Hospital, isn't it? We are also a tertiary facility, and I can also say that we basically have almost all the things that they also had. And that is how come our babies are also what? Doing better, isn't it? So it is almost going closer to the 80s, to the 90s, like in the developed world. So with a little support from other things, I am sure we will also be able to help the baby survive better. Next. So I just classified the various preterm babies from our 2022 data. And those less than 28%, our survival rate was 11.8. This is lower compared to the 28 from CCTH, right? Because I visited their facility last year, and they have more incubators than I do. They have more CPAPs than I do in my facility. So once you have all those things, your chance, because the babies need respiratory support, and if you don't provide it and provide it on time, they are not likely to make it. And so I believe that is why their chance of survival is way better than mine. However, as it goes up, our chance of survival basically becomes the same or even a little better than theirs. Next. So do babies who are born or pre-eclampsia do better than the general ones that I have talked about? Next. So pre-eclampsia deliveries from 37 for 8-month period. We have 58 mothers who were delivered by pre-eclampsia. 25 out of the 58 ended up at NICU. And like we said, more than half of babies that are delivered from pre-eclampsia and eclamptic mothers will end up at NICU. Out of the 25, 5 died. So overall, we had about 8.6% out of the 58 babies delivered from pre-eclampsia mothers dying. Next. So this is just giving you the month, the numbers, and those that survive. Next. Can move on, next one. All right, so pre-eclampsia outcomes. Pre-eclampsia leads to umbilical artery flow abnormalities. That results in placenta insufficiency. Because of that, the babies don't tend to what? Grow well. So they have what we call maybe IUG or severity of growth restriction. And like I said, so the babies will be born premature, and their growth is also what? Restricted. So in terms of age, they are born lower gestational age, and their weight is also lower. So double agony. So their chance of survival becomes a bit slim just because they are premature and they have severe growth restrictions. Next. So what are some of the problems that they tend to have? They tend to have premature, about 40 to 50% of babies born to pre-eclamptic mothers are premature. They have low birth weight, low ABGAS, and high rates of what? NICU admission. NICU environment is a war zone. It's a war zone. So once you come there, your one leg is out and your one leg is in. You either make it intensive care. If you are rushed to the intensive care, what does it mean? You are in trouble, isn't it? It means you are dying. So you either truly die, or you miraculously survive and you come out. So it's a war zone. So if babies that are delivered from hypertensive disorders will end up at the NICU, then their chance of survival also becomes what? Less. Next. So mortality of newborns increases with what? Increasing blood pressure also. When the blood pressure is way higher, your chances of dying, the baby's chance of dying is also what? It's also high. So the higher the blood pressure, the higher your chances of dying, and the figures are there to show. Babies that have low birth weight also tend to have some cognitive developmental challenges also, because they have a lot other challenges also. So apart from even when you survive, your chances of even having a normal quality life later also may be challenged. Next. So what am I trying to say? What I want to say is that I believe every pregnant woman should hear her baby cry at birth, isn't it? You hear a baby cry at birth. Should be able to feel the baby, put the baby on the mother's bosom, so they know, they feel their baby, the presence of their baby. They should be able to touch their baby and hold them and also breastfeed them within the first few minutes of birth. Survivor and thriving, not just survivor, because you can survive with what? A lot of disabilities. So survivor and thriving of a baby is a responsibility of all that provide care for the mother and baby pair. All of us, we need to what? Put our hands on deck. Everybody, the healthcare providers, the community, the family, to make sure our babies survive. Thank you very much. These are some of my references. I will take comments, questions, and contributions.
From the participants. Any question, comment on Dr. Pabi's presentation?
Our poor healthcare system. Please, I want to find out if a district hospital can refer straight to a tertiary hospital, regardless of an obstetrician in the district. We had a case of a severe preeclampsia, and then the obstetrician was at another unit. They called the unit, and then they couldn't reach the unit. But instead of referring to the tertiary, they pushed the client to the other hospital, and then by the time they got there, baby was dead.
Yeah, so there are systems in place in order to safeguard certain things. There are reasons why I think our healthcare system has structured such that from a district hospital, we are supposed to refer to maybe a regional hospital before a tertiary hospital and all that. That is for a good reason. But obviously, if you are not reaching the next person, you can go, you go higher. So yes, you can definitely refer to a tertiary facility. Wherever there is space, the most important thing is that you call before you send, so that they will be prepared before the patient comes. Because sometimes cases come and then you have nowhere to keep them. Maybe your place is home, and then they brought the baby because it's a tertiary facility. We are all struggling. Like I said, you come to my place, maybe I don't have respiratory support. I have. So if you call before coming, I say, for such a baby, I don't have what it takes, all that it takes. So try Range or try Kolebu or something. So it's always important to call, but you can definitely go. I think first. Thank you.
Thank you.
Please, I've been thinking about this thing since yesterday, that
now that we said the mode of deliverance should be SBDs compared to the CS for the preeclampsia women, I'm thinking that I want to find out if the mode of delivery now is the SBD. Won't the babies, the preterm babies, have some abnormality because their sutures are not mature? Then, like passing through the normal birth canal, won't.
Yeah,
compared to
thank
this?
you. This question that you are asking me, somebody will say it's above my pay grade. It's above my pay grade. I am a pediatrician, so I don't do a lot of I don't do deliveries. So it's a difficult question for me to answer. But I think that we are all looking at the best possible outcome. What will give you the best chance of survival? And if the evidence is showing that SVD is the one that will give you the best possible outcome, then we all try that. But it doesn't mean that by force everybody should have SVD. Because sometimes if the mother is unconscious, has had a fit, and is unconscious or is having a fit, you can't say, "Mommy, push." It's not possible. You get it? So, of course, preterm babies, sometimes they are developed spontaneously. Just the mothers will start the reaction membranes, they go into spontaneous labor, and they come in normally. And we deliver them normally. We don't say because you are preterm, let's go and have cesarean section. No, you do normal delivery. So where SVD allows, that is what is encouraged. Where it is not possible, you do a cesarean section. That is the pediatrician's answer to your ONG question.
Thank you for your excellent pediatrician answer to the ONG.
Thank you for your presentation. Please, I would like to ask, since we learned that most preterm babies born out of women that have preeclampsia tend to have cognitive challenges. But there is this saying that whenever someone gives birth to a preterm baby, they'll say, oh, your baby is going to be very, very, like, have high IQ. I don't know whether it's a myth. I want you to tell me.
Okay, so when we are born preterm, it doesn't take anything from you. The only thing is that, first of all, your chance of survival compared to a term baby is low. When you survive, you may also get some developmental challenges, or your chance of getting some of those challenges is also higher than somebody who was delivered term. Okay, but if you're able to escape all these problems, you are okay. Preterm babies may have what we call intracranial bleed. They may bleed into the brain and all that, and it may affect. That's what will give them the developmental challenges. So if you escape all these things, then you are okay. You don't have any problem at all. Evidence has shown there are a lot of people who were born premature who are professors and all that. So the fact that you are born premature doesn't mean that you are going to have developmental issues or what have you. However, what I mentioned was that if you have low birth weight, even babies that are born to mothers who don't have hypertension but are born with low birth weight also tend to have a lot of challenges. So you may be term, but you have low birth weight. You may have some challenges. So your chance of having the cognitive challenges is higher than if you were born term and you have normal weight. I hope you get it. But there are so many babies that were born with low birth weight that are also doing very fine. So it's not compulsory by force that because you were born premature and low birth weight, you are going to have this. Just that your chances is a bit higher than the ones that were born normally. Thank you.
Thank you very much. Any more questions? Okay. So please, let's clap. Let's give Dr. Pabi an Atama clap. I think we will miss the scholarship. Okay, so thank you very much, Dr. Pabi, for taking us through this session. So we have come to the end of this session, and in our conclusion, we want to say that the preemies and newborns, we want to remind ourselves that they need quality of care. That is just the basic of the wrap-up of everything that Dr. Pabi is telling us. And if we want to look at what quality of care is, or what quality is, we want to look at all the dimensions of quality. We want to look at how safe the care is. We want to look at the timeliness of that care. We want to look at how effective it is. We want to look at how affordable it is. So anything that has to do with the dimensions of quality, that is what we want to give to our preemies and our newborns. We want to emphasize the fact that empowerment of the woman cannot be overemphasized. I mean, what is so beautiful to have a 25-year-old who is unemployed, comes to you, and is assertive, is able to tell you what she wants and what she does not want, is able to contribute to the care of her child and even of her own self. So it's very important that irrespective of the socioeconomic level of an individual, we should empower them about their health. And the empowerment will come from us, those of us who know best, those of us who are endowed, and we are the healthcare providers. Let's give them the knowledge in a language that they will understand. Let's speak to them in the language that they will understand. And it's not necessarily in a local language, but breaking down the terms as much as possible, explaining to them in a way that they will understand, so that they can be able to contribute to the care of themselves and to their babies. Let's not forget that everything that happens starts from even before the woman gets pregnant, during the antenatal care and post-delivery. Every care that we give the woman from the beginning and to the end will lead to a successful or unsuccessful delivery and the survival of that child, whether at term or not. So thank you so much for being part of this discussion this afternoon, and we are hoping and praying that as we go back, we'll be able to do our best to improve the care of our newborns and especially our preterms. Thank you so much. And let's get down and join the rest of the team in the auditorium. Thank you.